Okay, so now let's introduce our presenters. Dr. Bader is currently the Vice President of Medical Quality at Hackensack Meridian Hospital. Dr. Bader has also served as a Clinical Associate Professor of Obstetrics and Gynecology at Temple University School of Medicine, as well as a Chief Medical Officer and attending physician at Crosser Keystone Health Systems. Dr. Bader received his bachelor's degree from Duke University, his MD from Georgetown University School of Medicine, his MGA from the University of Pennsylvania, and an MBA from the University of Massachusetts. Next, we have Dr. Jerry M. Zuckerman, is a board-certified infectious disease physician who specializes in hospital epidemiology, infection prevention, and patient safety. Dr. Zuckerman currently serves as the Hackensack Meridian Health Network Vice President for Infectious Prevention and is an Assistant Professor of Medicine at the Hackensack Meridian School of Medicine. Previously, he served as Chief Quality Officer and Medical Director for Infectious Prevention and Control at Einstein Healthcare Network in Philadelphia. Dr. Zuckerman is an alumnus of the University of Pennsylvania and received his medical degree from Cornell University Medical College in New York. He completed an internship and residency in internal medicine at Temple University Health, and both of a clinical and research fellowship in infectious disease at the Hospital of the University of Pennsylvania. Please welcome Dr. Bader. Dr. Zuckerman, we will be turning it over to you
now. Thank you, Caitlin. Tom, you're on mute, by the way.
Thank you. Well, I was just going to say what you said, so thanks. Thank you, Dr. Zuckerman, and I'll hand it off to you to lead us off. Thank you.
You would figure after 2 years we would get mute correct. So I am going to try to share my screen. And do you see slides?
It's good.
Okay, thank you. So thanks everyone for joining the call. We're excited to be able to participate in this conversation about COVID-19, provide an update, and answer any, try to answer, I should say, questions that you may have. You know, as you all know, COVID has been a very fluid situation over the past 2 years and continues to be fluid. And we learn as we go along, and you know, sometimes the things change, but it's all as we learn about a new emerging infection that we've never seen before. So what I hope to discuss is some overview of the COVID-19 trends, give you a little knowledge about the variants and why they matter, talk a little bit about efficacy of the vaccines, and then touch briefly upon COVID-19 and pregnancy. And given Dr. Bader's history as a obstetrician, you guys will be well served by his knowledge base later on with questions. So, you know, as I was thinking of this, you know, it's hard to believe that this has only been 2 years. And I thought, you know, maybe I should just, you know, put some milestones that occurred. And, you know, if you look back, it's been the first time this was even brought to the World Health Organization as a potential issue was the end of December in 2019, when China reported an unusual cluster of cases of pneumonia. And it was about a week later that they identified this as a new virus. It's called a coronavirus. Coronavirus is named because it looks like it has a crown. There are spikes that come out of the virus. And it was, the virus is named as SARS-CoV-2 because it seemed to be related to the original SARS virus, which we saw back in the earlier 2000s. In the US, the first case was on January 21st. On the 30th, the World Health Organization declared this a public health emergency of international concern. And in February, they had to come up with a name for the infection. And, you know, people were referring to it as the Wuhan virus, since that's where it was first identified, or the China virus. But in a means to not associate any of these infections or viruses with specific countries, they came up with the acronym COVID-19, which stands for coronavirus disease, the first two letters, and then the year it was first reported, which happened to be 2019, even though it was the last day of 2019. We're coming up to our first year anniversary, our second year anniversary in New Jersey. The first case was actually identified at Hackensack University Medical Center, and it was the week of March 5th. And, it's been quite a journey since then. Right thereafter, a week thereafter, the World Health Organization declared this a pandemic. And by the end of April, we've experienced over 1 million confirmed cases. So just think about that. Within 3 months, this virus had really traveled throughout the world, and in the US itself has experienced over 1 million cases. Fast forward to the end of 2020, we've had remarkable progress, and the FDA issued emergency use authorization of 2 vaccines, the Pfizer and Moderna vaccines. And then a couple months after that, the Johnson & Johnson vaccine also received emergency use authorization. So within a year from first identifying this virus, effective vaccines were developed to help prevent and minimize the consequences if you do get an infection. And then really the story over the past 6 months has been the emergence of variants. And in last summer and early fall, we saw Delta was the variant of concern. And then most recently, as you probably are all aware, Omicron has been the variant of concern. And then the other major events in November was that the Pfizer vaccine was approved for children 5 to 11, and the CDC now recommends booster doses for all adults. So where do we stand now? So as of today, there have been over 430 million cases in the world. So this is worldwide, and 6 million deaths have also been associated with the virus. And if you look at the countries, this is just representative of the countries, but these are the ones with some of the highest number of infections. And unfortunately, the United States is leading the way in terms of the infections that have occurred in our population. Over 70 million US citizens have been infected with SARS-CoV-2, the coronavirus. And unfortunately, we are now approaching 1 million deaths associated with this disease. So really extraordinary numbers. And to think that this all occurred over two years. And to put it in perspective, this is a little dated, but where does it stand compared to the deaths of US citizens in previous major events? So, if you look at some of the Persian Gulf Wars or 9/11 attacks, it was only in the thousands. The Vietnam conflict was about 58,000. World War II, 400 Americans died during that war. And really the closest two things are the Spanish influenza, which was the influenza pandemic of 1918, and then the ongoing HIV/AIDS epidemic, which started in 1994, and there have been 700,000 deaths contributed to that. So within the past 2 years, we've clearly exceeded all those major milestones and continue to have a rise in the number of people who are dying from COVID-19 infections. So looking specifically at New Jersey, this is kind of our epidemic curve. If you remember, back in March of 2020 was when these cases were first identified. And at that time, we had very limited testing capabilities. And people were really presenting to the hospital with very severe illnesses and requiring critical care. In reality, if we had testing availability, this curve would have been much higher. But since we couldn't diagnose the cases, we couldn't confirm that they existed or not. So this was our original outbreak. There was a lull, but while we had a lull, the rest of the country was experiencing surges, such as in the southeast and southwestern parts of the United States. Last winter, we experienced a big surge, and that was due to the Alpha variant. So that subsequently resolved. This past fall was the Delta, and then most recently was the Omicron variant. And so you can see that, as a variant emerges, it does, sweep through the population and causes a surge in infections and then subsequently hospitalizations and possibly death. So this is just looking at the same epidemic curve, but just based on race and ethnicity. And you can see that for really throughout the course of this, the number of infections occurring in the African American community have exceeded other ethnic and racial populations. The Latino community has a slightly higher rate than the white non-Hispanic community. So, it does represent a infection that has slightly affected minorities and underserved populations. And then this has also been a disease of older individuals. So this is looking, and I should apologize, this is actually for hospitalizations. So this is not just looking at infections, but looking at the number who have been hospitalized. And so that clearly impacted the Black community more than other communities. This is looking at hospitalizations due to age, and like many infections, the consequences of getting the infection tend to be more serious in older individuals, and you can see the hospitalization rates are for those over the age of 65 are much higher than the rest of the population. Looking at children and young adolescents, it's this flat line down here. But what you notice, there was an increase in during this latest Omicron surge. And so, we might have heard in the news that, the Omicron variant doesn't cause a severe infection as previous variants have done. But what I keep saying is that, if you have a very small percentage of a very, very large number, you're still going to end up with a large number. And that's really what drove our increase in hospitalizations and deaths. So talking about variants, I'm going to try and see if this works here. Do you see this screen now?
Yes.
Okay. So this is a little video that came out way back when, but I thought it can explain it better than me. So can you hear anything?
No.
I was afraid of that. Let's see here. Let me see. Actually, maybe if I go through here. Can you hear that?
No.
Yeah, you're killing me. One last thing. All right. Well, I'll give the verbal communication here. So this is the SARS-CoV-2 virus. These are the spike proteins that people refer to. And what it's saying is that, it goes into a cell, it hijacks the cell, and the cell then replicates the virus and it spreads. These are the codes that make up the virus, but sometimes there's a mistake that's made, and that's called the mutation. Some of those mutations don't have significant consequences, but when you have millions and millions and millions of people, you are going to have one mutation in that group, which will have a profound effect on the virus and make it have a selective advantage over other viruses or over other strains of coronavirus. So it may be more transmissible. What it's showing here is that the change may make it so that the virus is not killed off by our immune response. And then it just goes into vaccination. So that's really what it was trying to portray. And now I have to get rid of this picture somehow. Okay. Hopefully the picture's gone.
Yes.
So, you know, the viruses are on a mission, and they're on a mission to survive and to continue to survive. And so these mutations provide a selective advantage to the virus each time. So it could be either that it can be more easily transmissible between individuals, or it can evade our immune systems, meaning that, you know, our antibodies or other things that respond to infections won't work as well. This is looking, so these are just schematics, and the only thing I want to point out is, you know, so this is the alpha, this is representative of the spike protein, but all these colors here are mutations that occurred. And this is actually the Omicron variant. And so you can see that as time has evolved, there have been many, many more mutations in the virus. And these mutations in the Omicron virus fit both of these survival advantages. It clearly was much more transmissible than any previous variant, and was able to evade our immune systems. Oops, let me get back to the slide presentation. There we go. So this is looking at, so New Jersey and many, you know, the whole country take some viruses that we get from samples from people, and then looks at it and does some molecular testing to see, you know, is it the strain of virus that originated in China, or is it some other variant strain? And at the beginning of this, you can see that there were various different variants that were emerging in New Jersey. Some just disappeared, and some took off, like this blue, which was our alpha variant. And you know, this just said that it had a better advantage over the other variants that existed at that time. Whoops. Then came Delta. Delta is this brown. And you can see there that it really had a tremendous advantage over every other variant, and became the predominant one that was causing infections in the population in New Jersey. And then the red was the emergence of Omicron. And now that accounts for nearly, if not 100% of our infections that are occurring. And these variants don't arrive. So Delta first was recognized in India, and Omicron was first identified in South Africa. And it just shows how interconnected the world is, right? So what occurs someplace else is going to impact us, and what occurs here will impact other areas of the world. So just talking about vaccination, you know, this has been changing guidelines as we learn more, and as the virus changes, and as we understand immunity better. There are 3 approved vaccines in the US. Actually, Pfizer and Moderna have FDA approval. Johnson & Johnson, I believe, is still under emergency use authorization. Different age groups, only the Pfizer vaccine is recommended for children 5 and older. The other ones are only approved for those who are 18 or older. The primary series for these are the messenger RNA vaccines, or 2 doses. And as you know, Johnson & Johnson was 1 dose. And then booster doses are now recommended for all adults, regardless of the vaccine. But it's, and for the adolescent population, it's recommended for anyone 12 years and older. That's approved for, the Pfizer vaccine is approved for booster in that age group. But anyone older than that age is really a candidate for a booster dose. And you know, previously we used to say you're fully vaccinated, you're not vaccinated. But with things changed, it's now referred to as being up to date with your vaccine schedule, right? So being up to date now means having, you know, for the case of Pfizer, the 2 original doses and a booster dose. Now, it may be in 2 or 3 years, they're going to say you need another booster dose. And so at that point in time, an up to date would be, you know, these 3 vaccine doses plus the 4th one. So this is meant just to keep us in tune with what the latest recommendations are. The benefit from vaccination, this is looking at the most recent surge and looking at the rate of cases, whether you were vaccinated, unvaccinated, and whether you had a booster or not have a booster. You can see that for everything being unvaccinated, you have a higher risk of developing an infection than if you were fully vaccinated or fully vaccinated with a booster. And so the risk was at least threefold higher for those individuals who were unvaccinated for getting an infection. And you can see that this occurred, this is in the Omicron surge that we just experienced, and that everyone went up. So the vaccine did not necessarily prevent you from getting the infection, but it certainly made it less severe. And I think that's very evident on this slide here, where you can see that the risk of dying if you get infected is 41 times higher if you're not vaccinated versus if you are vaccinated. Really a significant difference there. And not all vaccines are effective in preventing an infection, but if you do get that infection, it helps to make it more mild and less severe. And this is looking at hospitalizations, and again, just reinforces similar findings that I just showed you. So for hospitalizations, for young adults, there was a 8-fold risk higher of being hospitalized if you were unvaccinated versus vaccinated. And you can see that in the older population, that higher risk reached up to 17 times for unvaccinated adults compared to vaccinated adults. And similarly, the booster provides even more protection, and you can see that unvaccinated adults versus those who've had a booster even have a higher risk of being vaccinated compared to the booster population, meaning that the booster population is not having that rapid rise in hospitalizations that we saw in unvaccinated individuals. You would think that the United States would have one of the best outcomes, being a very developed country and having a very sophisticated health system. This is just looking at deaths during the Omicron phase. So this is a rate of, and this is 20 deaths per 100,000, 10. You can see that compared to other developed countries, European countries, Canada, our rate of deaths significantly was higher than the rest of these other countries. And that may be partly related to the fact that we have lower vaccination rates, right? So this is comparing to individuals who've completed at least their primary series, and you can see that as a whole, the United States is much lower than other countries. And when we talk to boosters, we are also lagging behind there. So it's certainly something that may be contributing to these numbers, that the death rate in the United States is 63% higher than other large wealthy nations. Hospitalization admissions are 2 times higher than Britain, 4 times higher than the rate in Germany. And just showing you the difference in vaccination, especially for those over the age of 65. In the US, 12% of that population has not been vaccinated versus 4% in England. And more critically, those who receive booster, nearly 91% of the individuals over 65 have received their booster dose in England. So that's really quite significant differences between Europe and the US. And then just moving briefly to pregnancy. These are some of the numbers. Nearly 200,000 have developed cases. There is if you are pregnant and develop an infection, you do have a higher risk for hospitalization, and 20% of those cases were hospitalized. A smaller percentage of them get admitted to the ICU or require a ventilator. And you can see that even though deaths are small, they do occur in young pregnant individuals. Not only is there a risk to the mother, there's a risk to the baby, and there's an increased risk of both preterm birth and stillbirth. So vaccination is recommended for pregnancy and also breastfeeding. And, I think it's so you can see what COVID does in pregnant women. The vaccine does not cause COVID-19 infection. There is no live virus in the vaccine. It can't transmit the infection, and so will not cause that infection in individuals. The vaccine is very safe in pregnancy. There's been no documented increase in side effects or reactions, and there's 3 nationwide monitoring systems for COVID vaccination, and there are registries for pregnant women that continue to assess this. And there's been no increased risk of miscarriage for those who've been vaccinated either right before or during their pregnancy, and especially early on in their pregnancies when these concerns are most high. So a lot of those concerns for complications don't exist. And what does the vaccine do? So, first and foremost, it decreases the risk of infection, but most important, well, not most importantly, but also importantly, decreases the risk of hospitalization if infections occur. But it also provides protection for the baby. And so when we give a vaccine, we develop antibodies in pregnant moms. Those antibodies can cross the placenta and are found, they recorded them in umbilical cord blood. And so they presumably are in the baby's blood. And they would provide protection for that newborn for a few months after they're born. So these antibodies are protect both the mom and the newborn from getting infected. And you can see that babies who were 6 months old or less, whose mothers were vaccinated, were 61% less likely to be hospitalized with COVID-19. And the majority of babies who are hospitalized were born to mothers who were not vaccinated. So clearly there's a twofold purpose to vaccinating pregnant individuals. And I will also say for breastfeeding, there is also antibodies found in breast milk, and that may also provide a protective factor for the baby. Questions about fertility have also arisen. No evidence yet that it causes infertility. This was a large study that looked at menstrual cycles. What they found was vaccination was associated with less than a 1-day increase in a cycle length. Compared to women who did not receive the vaccine, but this change was temporary, and they quickly, after 2 or 3 cycles, reverted back to their previous, normal cycle patterns, and there was no effect on the duration of menses. A small study looked at sperm counts in men. And looked at the sperm counts prior to vaccination and 70 days after the second vaccine dose, and found there was no decrease in any sperm count parameters after vaccination. So, again, this preliminary stuff that really helps emphasize that there's little and to no impact on fertility. And in fact, we've had plenty of vaccines out there. And similar, vaccines that are inactive have never been associated with increased infertility or both women or male. And then the final thing before we open it up for discussion, just some recent changes in quarantine and isolation. And for isolation, as you know, the CDC came out with some new recommendations and now recommend that if you test positive, you should stay home for at least 5 days. Previously, it was at least 10. But then if you go out after that, you should continue to wear a tight-fitting mask, a well-fitting mask to prevent transmission to others. However, if you have a serious illness, and presumably you would have been in the hospital for that, isolation should still be 10 days. And if you are immunocompromised in any way, it may even be longer than that. Attempt to get people more out of isolation and back to work earlier. And then quarantine, the difference now is that if you are, quote, up to date with your vaccines, as I discussed earlier, and you were exposed to COVID-19, you do not need to quarantine, but it's still recommended to get a test 5 days after your exposure. But if you're not fully up to date, then quarantining at home for at least 5 full days, and then doing a test to make sure that you're negative. And just to draw the distinction between isolation and quarantine, isolation is when someone with confirmed infection, you're keeping that person away from others. So you're protecting the other population. And quarantine is when someone has close contact with someone, then that's when you separate them in case they happen to develop the disease. And, with COVID-19, you can transmit the infection up to 48 hours prior to the onset of symptoms. So there is a possibility of being contagious, even though you may not know that you have COVID-19 infection. And I think that was my last slide. Certainly encourage everyone to get their booster dose. To help revigorate the immune system and ensure that it really helps prevent serious sequelae from getting the infection, if not getting the infection itself. And I will stop sharing my screen there and give it back to Maria and Caitlin. Are you guys there? And Maria, you're on mute.
We are here. Can you hear me okay?
Now we can, yes.
Thank you. Sorry, Caitlin and I are navigating some tech. So thank you for your patience. Thank you for that presentation as well. Really insightful, helpful information. We do have some questions prepared for a Q&A. And there is an opportunity as well. If anyone has questions they'd like to put in the chat, we can incorporate those as well. So you did share some helpful information about the COVID vaccine with regard to, no evidence that it would impact fertility, little to no impact on the menstrual cycle. Can you let us know a little bit about if the COVID vaccine has any impact on a developing baby during pregnancy?
I'll take that one if it's okay, Dr. Zuckerman.
Sure, Dr. Bader, be my guest.
So a couple of things. The first one was, and I think it's important to acknowledge that the vaccines, the Dr. Zuckerman gave that excellent history of how things got started. And Pfizer and Moderna actually started doing their trials of vaccines right around the exact same time that the World Health Organization declared a pandemic in March of 2020. Initially, pregnancy was excluded from the trial. However, as many of you can understand, best laid plans, people who were thought not to be pregnant were pregnant, and people who got the vaccine became pregnant. And so initially there were several hundred pregnancies in that first cohort. But since then, we have had, I can't remember the number that Dr. Zuckerman showed, but literally tens of thousands, not just of pregnancies, but now of children born to women who were vaccinated. And you do have to say, obviously, so far that the vaccine has not been associated with any abnormalities in the babies. As Dr. Zuckerman said, also not associated with infertility or loss of the pregnancy, miscarriage, any of those events either. The second thing I would say, and this just draws on another point that Dr. Zuckerman made, is we do have extensive experience with vaccination in pregnancy. Most vaccines are considered safe in pregnancy. And as a practicing obstetrician, I certainly vaccinated plenty of women with many vaccines. There are a few vaccines, rubella is one of them that can't be administered in pregnancy. I think varicella is another one, but most vaccines can be administered in pregnancy. So we literally have decades of experience with vaccines in pregnancy. Granted, the mRNA vaccines are a new technology, but there are several vaccine technologies, and other than live viruses, we have used them successfully in pregnancy with no untoward effect. And the final comment I would make is, whether you think it's a good thing or a bad thing that there's been a lot of vaccine reluctance in the United States, it has cast a very bright light on outcomes. And so, it is kind of amazing to say that even though all of these vaccines are relatively new, we probably know more about these vaccines than we do about a lot of the other vaccines, because we really have looked at them so carefully. And again, whether it comes to pregnancy or whether it comes to the general population, I think you can say generally, with the exception of anaphylaxis and myocarditis, mostly in young men, they do seem to be extraordinarily safe. But the short answer is we have tens of thousands of pregnancies at this point that have occurred in the face of vaccination, and we have not found any increase in any untoward outcomes in the newborns. Dr. Zuckerman, I don't know if you have anything else to add.
No, that was very thorough. Thank you.
Can you talk more about anaphylaxis and myocarditis in young men? Myocarditis, excuse me.
Sure. So definitely two separate phenomena. So, anaphylaxis is a severe allergic reaction, usually happens immediately after the vaccine. There are two agents associated with the vaccines that have been associated with most anaphylactic reactions. Anaphylaxis is still uncommon, and allergic reactions in general are uncommon, but anaphylaxis in particular is relatively uncommon. In terms of myocarditis, Dr. Zuckerman, I don't know if you want to talk specifically about the myocarditis phenomenon. And again, I know it's happened in young men and women, but particularly in young men.
Yeah. So just in terms of the anaphylaxis, when these vaccines first came out, there was some notable, well, at least one notable event in England about someone developing anaphylaxis. I remember it's probably more than one, which raised that concern about, these vaccines may be very reactogenic. But our experiences really have that anaphylaxis and allergic reactions is very, very rare and few. I've administered plenty of vaccines and have yet to see anyone have an allergic reaction to it when I've administered it, or soon thereafter. In terms of myocarditis, myocarditis is inflammation of the heart muscle. And so this was something that emerged. So I remember I mentioned that we have some monitoring systems in the US, and those monitoring systems are for exactly something like this, for something that's very rare, but it has enough scope that it can identify a very slight increase in an unusual phenomena. And so it was with these surveillance systems that this problem with inflammation was first identified, and then they subsequently, and vaccine has been administered to millions and millions and millions of young adults. This is highest in young adults than other individuals of different ages, and found that it is a little more frequent in men than women, and occurs slightly more frequently if after your second shot than the first shot. But most importantly, the evidence is that the inflammation is relatively mild, and is not permanent. So these tend to resolve and over time, and people's heart function and returns back to its baseline. I forget the exact number, but in 1 million doses, we're probably maybe 20 to 50 cases that are administered, that myocarditis may be reported in 1 million doses. But remember that if a young adult gets COVID-19 infection, they also have a risk of developing myocarditis, and that risk is much higher than the risk of developing myocarditis or inflammation of the heart muscle after vaccination.
Thank you for taking a minute to address that.
Thank you.
Wonderful. Thank you so much. So we do have a few different categories of questions. There are questions in the chat. There's a question in the chat as well. So if anyone else has anything they want to add, please feel free. We might get to that question towards the end. On the topic of vaccine, pregnancy, breastfeeding, I know that you shared the benefit that there are antibodies found in breast milk of vaccinated women. Are there any other impacts of COVID vaccine on breastfeeding that you can speak to, or any information in addition you'd like to share?
I don't think so. I mean, the vaccine does not impact breast milk production or quality or quantity. And yeah, as Dr. Zuckerman pointed out, the so-called passive immunity, where the baby gets the benefit of the mom's antibodies, it's not unique to COVID. I mean, babies get passive immunity from a number of different antibodies from mom. And I think the nice thing is, in addition to knowing that initially all we knew was that the antibodies were in the breast milk, then subsequent research that Dr. Zuckerman pointed out shows that it seems that that's probably one of the factors that contributes to the protection of the newborn. That and the fact that if mom's vaccinated, it's very likely there are other family members who are vaccinated. And so all of that it's typical of the protection of the newborn, is that it's not just the antibodies, it's not just the vaccination of family members, it's the whole picture that seems to protect newborns. But no, there really isn't anything more to say about the impact of vaccine on breast milk. It really has no impact except to add the COVID antibody to the mix of antibodies that babies get passive immunity through breastfeeding.
Okay. If a pregnant woman has COVID, what symptoms should she pay attention to? And is there anything, that should tip her off that she might visit the emergency room?
That's a great question. So, the first thing is, I would say for anybody who has COVID, they should be cautious and look in particular for worsening respiratory symptoms. Obviously the symptoms of COVID, people feeling tired, fever, those are common. And certainly those are things that can occur with pregnancy. Certainly, I would advise a woman with COVID to have a somewhat lower threshold for, calling their healthcare provider or getting evaluated. The big concern with COVID and pregnancy is the fact that pregnant women have somewhat different lung function compared to non-pregnant women. And so when you've got a circumstance where lung function is already impacted by pregnancy, and then you have a disease that can cause significant lung dysfunction, that's what I think sets up women for potential more serious complications. When you compare, say a 35-year-old pregnant woman to a 35-year-old non-pregnant woman, if their health conditions are all the same, pregnant women are slightly increased risk or significantly increased risk of complications. Again, most pregnant women don't have complications due to COVID, but they could. And so my particular focus would be, when I'm talking to a pregnant woman, is feeling shortness of breath, difficulty speaking in full sentences. If you have to interrupt your sentence to take a breath because you're not able to complete a full sentence. Again, it's not unusual for pregnant women to feel somewhat short of breath subjectively, but that's why I think it's important to have a low threshold, and when in doubt, to contact people. But that'd be the short answer, is to focus particularly on any perceived compromise of breathing or lung function. That would be the major concern.
Yeah, if I could just add to that. So I think if a pregnant woman is, diagnosed, well, first, if they have symptoms, they should get tested right away. And if their test is positive, then they certainly need to have a conversation with their obstetrician or primary care doctor. And as Dr. Bader mentioned, pregnancy is a risk factor for increased complications. That women may have other risk factors too. There may be obesity is a risk factor, diabetes is a risk factor, and the more risk factors you have, the higher your risk for complications. What the discussion is with obstetrician or primary care physician is that we now have, we have outpatient treatments available for individuals. So previously, they were called what we called monoclonal antibodies. So that was an IV given through the IV and infusion. And monoclonal antibodies is just, all these antibodies that are manufactured to, against the spike protein, which are the same type of antibodies that are produced after we get vaccinated. More recently, there have been some oral antiviral agents, oral medications that became available. There are two, actually. Only one of them is really, it can be given to pregnant women. The other one is potentially mutagenic, and it's not recommended for anyone who's pregnant or planning on becoming pregnant. But the other one has been found to reduce the risk of complications by, I think, close to 90%. So it's important to have that discussion early on in a person's illness to see if they're a candidate for one of these type of treatments based upon their risk factors.
Okay, thank you for that. Moving into the topic of the COVID vaccine and children, can you speak to how safe the COVID vaccine is for children?
Yeah, so, again, really no evidence that there's any increase in side effects. It's just, we already talked about the inflammation of the heart muscle, which is, primarily in young adults and seen in adolescents. But that's really the only one that I've seen emerge. When you compare side effects and vaccine reactions in children, the profile is very similar to adults. So there hasn't been anything that really stands out as being a concern in children at this point in time.
Do we know when vaccine eligible children may need to receive a booster?
Yeah, so I'll bring out my crystal ball now. And so, this has, been a little confusing. And I think, that's been one of the issues during this pandemic, is that sometimes there's multiple messages going on there. So this is being looked at, and currently there are studies looking at the efficacy in children less than 5 years of age. In general, young children, infants, tend to require extra doses of vaccine to make sure that the immune response is good. So we see that frequently in many of our vaccines. And originally, because we were in the midst of Omicron, the company was applying for emergency use authorization based upon their data from 2 doses. And then subsequently, it's been decided that if it gets approved for 2 doses, but the studies eventually show that it's really a 3-dose series, that this would cause a lot of confusion going forward, and perhaps some mistrust in the population of, you told me I needed 2 doses, now you're telling me I need 3 doses. And so I think the prudent option was to wait until the study is completed and all the available information is out there. So we can, the company and the CDC can make a solid recommendation of whether this is a 2-dose or a 3-dose series. And I might even say that in adults, in retrospect, the adults might have been a 3-dose series originally as too, if we knew more about how long immunity lasts. That might have been one of the original trials done as well. So that's why it's currently not being looked at by the FDA. And I would expect, hopefully, by early spring or mid-spring, that hopefully this will go before the FDA for evaluation.
Thank you for sharing that.
I do want to point out one thing, though. There has not been any concerns about safety that have led to the delay. The vaccine does appear to be just as safe in young children as it has been for the other populations. So,
yeah.
Wonderful. On the topic of the COVID vaccine and booster shots, similar to the participant who asked in the chat, if the effectiveness of the third booster shot wanes, can we speak to how effective the booster shots are?
Yeah, so when you talk about the effectiveness, there are really three ways to talk about it. One is the efficacy against preventing the infection. One is the efficacy against hospitalization, and then one is the efficacy against dying from the infection. And what we do know is that in general, as you go farther out from your vaccine, including the booster, the efficacy in preventing infection decreases. It's still somewhat effective, but it's not as high as it was, in the first 2 months or 3 months after you got vaccinated. But what seems and has remained throughout this whole vaccine story is that it still is highly protective against hospitalization and for death. And I think one of the slides I showed you in the Omicron, the hospitalization for vaccinated, for unvaccinated, vaccinated, and the lowest rate of hospitalization was in that group that was fully vaccinated with a booster. And some of those folks have been 5 months now or 4 months now out from their booster shots. So, we are learning as we go along, and understanding how long our immunity lasts. If you think about the flu vaccine, flu vaccine, you should be getting a booster, not a booster, you should be getting a shot each year, right? Just to, the virus changes a little bit, and our immune system wanes. So that's why it's recommended on an annual basis. We don't know yet because we haven't had the vaccines for long enough and the virus around for long enough. I think there was a study in the New York, at least I saw in the New York Times reported this morning, and haven't had a chance to read it, but it suggested that immunity can remain even for a prolonged period of time after a booster. And there are two things that vaccines, so there are two ways we fight off infections. One is by these antibodies, which are produced by B cells. And there's a whole nother immune system in our cells that's moderated by the T cells, which you can't really measure. But it's felt that the vaccine activates both those T cells and primes them for being activated if they ever get exposed to the virus in the future. So it's a multifactorial response to vaccination, and presumably that will help. That's presumably why it reduces the risk of hospitalization and death, and hopefully will provide us with long-term protection. But studies still need to continue to monitor that at this point in time.
Is there and I just want to say that both of you have refreshingly, said that we don't know what's going on at all times. Is there any responsibility on the part of public health authorities to restore some of their credibility by coming out and saying we don't know everything that's going on at any time? And I know that's maybe a difficult question, and I don't want to put you on the spot, but there's been some damage done to the credibility of public health authorities.
Yeah, no, I mean, it's a fair question. We I don't know if any of you remember the anthrax attacks, back in 2001. But some of the pitfalls was that there was miscommunication, right? And that is the bane of one of the banes of the public health response is, you want to assure the public, but you don't want to provide information that may change, rapidly. And so you have to acknowledge the uncertainty of that. Certainly in our health system at the beginning, we fell into that trap. We would recommend one thing, and then, sometimes it was a day later we had to switch it, or maybe it was a month later. And so, I've certainly learned to say that we are learning, and we need to be flexible as we go along. The other comment, and this was one that, I don't think, I appreciated, or many others appreciated, was how political this became, right? And, when I've studied about pandemics and learned about pandemics, politics never entered into that discussion. It was more about, this is how we wish to respond. These are the interventions we should do. And I think that whole political discussion has also enhanced the mistrust and misinformation out there. So it's a complicated thing, and I do think the public health authorities certainly need to be very forthright and honest about what they know and what they don't know. And we have to, communicate in such a way that the public does understand that this is the best knowledge we have at the moment, but that, we want to learn and improve as much as them, and to make sure that our long-term goals are the same, is to keep everyone safe and to prevent infections and make this pandemic go away.
The politics have certainly been a problem, and I appreciate your response. Thank you.
You're welcome.
Do you have any information about why the different types of vaccines vary in their efficacy?
Yeah, there are, so they're different, they're made differently. So the Pfizer and Moderna are based on this technology called messenger RNA, and the Johnson & Johnson and some other vaccines are based upon, having a virus vector deliver it, or some of it is just the antigen that's being administered. And, this is not unique to this vaccine. We have different versions of vaccines for different things. The one I think about is the vaccine for shingles. And, there was a vaccine that was kind of a live modified virus that first came out. And then a second one came out that worked differently and didn't have any live virus. And over time, we learned which one was better. And over time, we learned that the second one was the better one. I think with this one, we've also learned that the messenger RNA vaccines are superior to certainly the Johnson & Johnson, and have much longer and profound protection against SARS infection, the coronavirus infection. So it gets down to really kind of the delivery systems of the vaccine, and specifically what mechanisms they trigger to mount an immune response that accounts for the differences.
Thank you for that. You have any information for us about, how our understanding of COVID has evolved since the beginning of the pandemic versus now?
How many hours do you have? Yeah, no, we've learned a lot. And, I think our biggest learnings certainly are, one, that the virus changes over time, and that the variants that emerge are clearly very important. I think, two, that non-pharmaceutical interventions such as masking and social distancing work and reduce the likelihood of transmission. It doesn't mean we have to go into a total lockdown like we did back in the spring of 2020, but we need to be able to tailor our responses to how much disease is in the community. And there were some other learnings there.
I guess I would say humility, Dr. Zuckerman. That's certainly one that you have emphasized. We have to constantly understand we don't understand everything.
Yeah, that's for sure. Yeah. And I had something else on the tip of my tongue that just escaped me. But communication is clearly critical in a pandemic, and being able to message things importantly, and just the whole evolution of the vaccine is just incredible, and how you can tailor something so quickly for and effectively for a response to a new virus is amazing.
Do you have any information about potentially the causes of, it's become known as long COVID, who might be at risk of developing long COVID symptoms, or any implications?
Yeah, that's emerging information. There's no test that you can do that says, I have long COVID or I don't, right? Or post-COVID. It's a constellation of symptoms that are usually fairly vague or subjective and difficult to measure, with a blood test or anything. So, maybe lack of clarity in thinking, and maybe unusual fatigue. And right now, I think there's just speculation as to why it occurs. Mostly, I think it's felt to be a ongoing immune response to the virus. So sometimes infections trigger autoimmune diseases. We've seen that with other infections and rheumatological diseases. And so something certainly like that may be emerging. And there was just something I saw that certainly the severity amount of virus in your initial infection may predict the likelihood of developing long COVID. Diabetes may be a risk factor. And the incidence has been reported anywhere from 10 to 30%. But since there's a lack of clarity and definition in how to diagnose, it's hard to know what exact number that is. So we have a lot to learn about this syndrome, and over time, hopefully that'll emerge as quickly as we learned about the initial infection.
Thank you. Since the beginning of the pandemic, our last couple of questions here are, has the guidance changed on how best to protect ourselves against COVID in terms of mask wearing, social distancing, and sanitation? One thing I want to add to that as well, I did get a private message in the chat on a question about mask mandates in schools. Any insight into how parents should kind of go about following the new guidance, knowing that all children in schools might not be vaccinated?
I'll deal with the first part, and I'll let Dr. Bader deal with the second one. So what have we learned? I don't know if you remember back in, maybe some people didn't do it, but you would have your groceries delivered and you wipe everything down with bleach or disinfectant wipes. We were worried about touching doorknobs and stuff and the virus being transmitted. So certainly we've learned that the virus is not spread by the environment, touching the environment that we're in. So that has really been not a source of transmission. It's transmitted by talking and coughing. I think in terms of transmission there, we've learned that in the past we used to say respiratory infections are transmitted either by these droplets, which are relatively, when you see someone sneeze in the light, you see this spray that comes out. I know that's a little gross, but that's what we would call droplets, as opposed to something like TB or measles, where they're very, very small in size and remain in the air for very long periods of time. Originally, COVID was felt to be transmitted by droplets, and so that's why we were wearing just a surgical mask. But as the science emerged, it really, became evident that it's really a combination of both droplets and the smaller particles that may remain in the air for prolonged periods of time. And that's certainly important for if you're in an area like a hospital where you're treating these patients, why we go to respirators now instead of wearing face masks for those patients who have COVID. Back in when this first came out, the recommendation wasn't for everyone to wear a mask. And that certainly has come out over time and has really shown that it does protect against infection. And I'll say it also protects against other viral infections. I mean, we've seen minimal flu since all this happened because everyone wears a mask, or most people wear a mask. What else did we learn? And just a interesting learning, I think, just came out recently. If we monitor sewage and the virus in sewage water, that we may be able to predict when a community is going to see a surge. So it seems to increase the quantity in the sewage a couple of weeks before you start seeing it really surge in the community. So that may be very important for us in the future, to say, okay, look, you guys are having a lot of this in the sewage. Let's go to masking for the next, month, and then mitigate the what we know is coming, and then when the things drop off, revert back to whatever baseline we've decided on. Dr. Bader, you want to do the school stuff?
I think the schools is such a complicated topic because it's impacted by prevalence in the community, vaccine incidence in the community, and also obviously the balance of a relatively low risk for the population impacted versus the huge benefit from being in school. And I think Dr. Zuckerman didn't highlight this, but that's that one graph that showed the Omicron with some hospitalizations. Those hospitalizations were in the young kids. The school-age children hospitalizations is extraordinarily low. So I think it's really a social decision more than it is a medical decision. I think there's some people say, well, they're just masks, and others say, well, yeah, but masks are a pain in the neck. They interfere with the facial recognition that's so important as children are developing social skills, and obviously just being in school in general is important. So I think the good news is we've weathered the Omicron surge, and we seem to put ourselves in a position now where people can get back to I don't want to say normal, but back to the new normal and back to school. And I think I'll leave the mass decisions to the school boards and the parents and the leaders of the schools so that they can sort out what's best in their community.
Yeah, and I think also we have to also when it comes to masking, we're certainly going down a path where these mandates, they're not going to be mass mandates, but we have to respect individual decisions if people choose to wear masks and not make them feel isolated or ostracized because of that choice.
I apologize for going for the hat trick on this one, but I'm personally vaccinated and boosted. My father is unvaccinated. He seems to really be against getting vaccinated at all. But he also takes the pandemic very seriously, and he doesn't feel comfortable going to a restaurant for his health and the health of others. Is there? I know this is crystal ball, but is there any sense of like herd immunity or a time when we might feel safer from a general population perspective? And keeping in mind what you both said about humility, under the circumstances.
Yeah. So the virus is not going to go away. It's going to be with us. Our hope, and my hope, is that we will see kind of this rolling surges over time. It may be seasonal. But as the population becomes more immune from either previous infection or vaccination, hopefully we will see less serious illness and less hospitalization and less death. That's my hope at this time. Now, the unknown of all this is one, how will the virus change? And will it change such that, it's almost putting us back at the beginning where it's, all our immunity won't protect against it. So that's an unknown. And, I don't know what, our response, we as soon as things are better, we turn off the spigot. And I don't know if that's the right approach. So, are we just going from extreme to extreme? I think we have to learn, but I'm most concerned about the variant emergence. And then the other thing is that that immunity will help the general population. I'm not sure how that will necessarily help an individual who is unvaccinated or has no immunity, I should say. And if they remain unimmune, then they, no matter how little virus may be circulating or how less severe it is, if that person still gets infected, then they may have the consequences that we are seeing now in an unvaccinated individual, assuming that there's no other therapeutics or something that becomes readily available.
So thank you so much to Dr. Zuckerman and Dr. Bader for taking all this time and providing so much information.
Thank you.
Thank you. Take care, everyone. Stay safe.
Take care. Be well.